Good afternoon, everyone, and welcome to QItalktime, broadcasting from Dublin Castle from our conference today. So for those of you who aren't here, we're delighted to be able to share some of the information that's been shared today at the conference, at the All-Ireland Schwartz Rounds and QI Conference, People Make Change Happen. So we have a large panel today. We're delighted to have a large number of people with us to discuss some of the things that we're presenting today at today's conference. So first off, Dr. Philip Crowley is going to introduce our speakers, and then each speaker will give us a little bit of information regarding the topic that they're today presenting on at the conference. So without further ado, I'll hand over to Philip.
Thank you, Oisin. It's lovely to be here and to be with you all and to share, I guess, to bring you into what we've been doing here today and to involve you in it. We've got a wonderful panel of participants today. Mandy Gormley, to my right here, the Transformation Manager for the Western Health and Social Care Board, who is an expert in flow and joining up primary care and secondary care and all the things that are very, very important to us as well. Beside Mandy, we have Jocelyn Cornwell, who's the founder of the Point of Care Foundation, who has been our partner in spreading Schwartz rounds throughout the island of Ireland. So lovely to have you here, Jocelyn. John Fitzsimons is beside Jocelyn. John is a consultant paediatrician and he's our clinical director in the National Quality Improvement Team. And finally, but not least, Stacey Lally, Associate Director for Professional Development and Community in the Q community. And again, the Q community is something we formally joined and announced today, and we'll be welcoming people to join the Q community over the next coming months.
Fantastic. And before we get started into our discussions, so we just want a little bit of housekeeping to run through. So you can dial in the chat box, you can click on the blue bubble in blue, like a little speech bubble, and you can type in any comments or questions for the panel as we go along, and we'll deal with those as we go along. So we want to keep it as interactive as possible, so please do keep the comments coming. For sound, you can listen over the computer, but also you can dial in, and the sound is normally better if you do so using the phone number there and the event number. It is also in the chat box for your use. And we are active on Twitter at QItalktime, and also today's hashtag is #SchwartzRounds. So if you wanted to look that up to see any of the content from today's conference. So without further ado, I'll hand over to Mandy.
Good afternoon, everyone. I'm going to tell you a little bit about flow coaching. And its inception was in Sheffield in England, and it's an approach supported by the Health Foundation. And it's a national programme. And six of us went to Sheffield and trained as flow coaches, and then came back and set up a flow coaching academy for Northern Ireland. So what the approach is really about is, I have worked for many years with teams doing quality improvement projects, doing microsystem coaching, and quite often teams can only get so far before impacting on others or coming across things that are outside their control. So this looks at a whole pathway approach. So it's normally a condition-based pathway, and it's how the patient actually experiences care right through a patient's journey. The second part is around improvement science. This is your normal quality improvement science, but we work very much with the team in doing an assessment of their service. So we look at things like what the staff feel about service, what do patients think. We look at process mapping the whole patient's journey and look where there's duplication or issues. We get the pathway team to develop a vision. So we gather lots of data and information about that team, and then we get the team themselves to see that information and then to vote on it. So they, as a whole, will decide what type of work they're going to work on from the bottom up, what's actually important to the team. And because we have all of that information, it's not just hunches and ideas or maybe what the manager wants to do, it's very much what the team wants to do collectively. So once that happens, then we start to introduce quality improvement, and you'll see on the slide, that's the flow coaching roadmap. And it's things that you're probably familiar with, where we do look at aims and driver diagrams and PDSA cycles. But what makes a difference is that we have weekly coached meetings, and that's the third element of the three circles there, and that there's an independent coach and a clinical coach in every one of the big rooms where those staff come together to make improvements. The clinical coach is someone who is very well respected within that pathway, someone who can help break down barriers, someone who's emotionally attached to want to make the pathway better, And the independent coach is someone that comes with a fresh perspective, different pair of eyes, and normally that person will have some quality improvement experience. So we have those weekly coach meetings. Patient stories, patient involvement is a big part of that. We do look at qualitative and quantitative data, and it's very much an area for reflection where the team can look at what's working well and what they need to improve. So the Flow Coaching Academy within Northern Ireland, we started off with 3 big rooms, and the one that I coach is the elective orthopedic big room. We also have a gestational diabetes and a frailty big room. So they have been going now for almost, just over 18 months, and we started to see real results. Some people, we do look at quick wins because some people can become very impatient and want to make improvements very quickly. However, a lot of these problems have been historical, have been going on for years and years, so some of them will take a wee bit longer. But we have started to see things like reduction in length of stay, reduction in unnecessary bloods within the orthopaedic clinics and on discharge. We've introduced virtual clinics for gestational diabetes, and there's been reductions in actual appointments and waiting times for pregnant mothers. And within frailty, we've also reduced the number of people who attend an emergency department aged over 75 who are actually admitted to hospital. We've also lots of different types of service user involvement in our big rooms. We shadow patients to see what it's like throughout their journey. We have patient stories at the beginning of the meeting. We have focus groups. We have patients involved, in, for example, in our big room, in developing pictorials and videos on what to expect from hip or knee surgery. And we have a fantastic service user who's very much involved in the frailty big room. She comes every week. She plays a really active role, and she has innovative ways of involving her friends. She goes away and maybe emails 15 of her friends and comes back the next week with real-time feedback. So that works really, really well. We started our Flow Coaching Academy in Northern Ireland last May, and we're almost finished our first cohort. And we have 11 additional big rooms, 6 from within our own trust and another 5 from across Northern Ireland. And we're just about to commence our second cohort now in May. What is more difficult to measure in the big room is actually how it feels the staff. And it's very interesting because quite often members of staff from across the pathway didn't know each other, didn't realise what issues were in each part of the patient's pathway. And this has really built relationships. It's all about people, looking at behaviours and relationships. That's why the team coaching is really, really important. And we get such good feedback from the big room. People call it Feel Good Friday. People say that they've actually stayed on their posts because of this is happening, and they feel that they can actually make change. And here's some words on the slide that's some of the feedback that we've got from staff. Thank you.
Thanks a million, Mandy. So we thought we might have a little bit of discussion in the room regarding the flow coaching. So one of the things that has sparked something with me is around the difference between this model and perhaps the collaborative approach. Maybe you might discuss a little bit about that, because we in the National QI team would deliver a lot of collaboratives, and would be interesting to hear from you a little bit on how you see it differs.
Yeah, well, I suppose it's very similar to any collaborative approach, because the big room allows them for 1 hour a week staff to come together to make improvements. Their voice can be heard. It's a very flattened hierarchy, as we talked about earlier this morning, where everybody's voice is important, so everybody gets an opportunity to contribute. It allows, I suppose, as I said, staff from across that pathway that didn't know each other. Now they say they can get business done because they've got to know members of the wider team. And I think they do believe that actually working collaboratively, they can get results.
So probably that weekly touch point as well, whereas the collaborative, it's
Yeah, we do have collaboratives in Northern Ireland where people get together from across the province, but this is really within an organisation. Possibly you can have other organisations, so we talked about general practice, more community services, so right across the pathway can come together to do the work.
Could I ask a question? Just wondering, what do you do in the big room? I mean, you've got people together. There's obviously, I guess, there's some subject matter expertise, there's patients, there's the staff at the different parts of the pathway. So what do you try and achieve in the big room? Do you train in QI, or what do you do?
It's a real mixture. We use effective meeting skills because people are really busy. They give us an hour of their week. It has to be really productive. So it's very action focused. So we have
1 hour a week.
1 hour a week.
Okay.
So we have a timed agenda, start and time, finish on time. We evaluate all of our meetings to make sure that they are productive, and that's why people come back. We initially in the journey, we do a lot of quality improvement training. So once those teams have decided the first thing that they want to work on, they voted on it. So taking them through, teaching them things like driver diagrams, teaching them even to process maps, all of the quality improvement skills. Most of them had no idea what a PDSA stood for or whatever, and now quite frequently they say, oh, we've tried out a Plan, Do, Study, Act. So there's quite a lot of teaching initially. Also the relationship building initially, because a lot of people didn't know each other. And by using effective meeting skills, we rotate the roles. So there's a leader, a timekeeper, a recorder, and a facilitator. So the business manager quite often is the leader, and or the business officer, and the consultant might be taking a few action notes. So we do that. We also try to bring in all of the different improvements happening within the area so that people know what's going on. So we might bring speakers in. We've actually got IT involved coming to the big room, and they have resolved lots of problems. So it's just a real mixture of improvement work and trying to innovate as well.
And do you have any IT platforms to support them outside of the big room, or is it just purely that once a week? Can they share stuff online, or that's something that we would have challenges with?
Well, we have a SharePoint site, so we've all the big rooms on the SharePoint site, so you can go in and look at notes, because not everybody can get to the big room, so we try to share as much as possible. So there's lots of information, slides and presentations and things on that. We also have a newsletter, a quarterly newsletter that updates staff as well around that. And I suppose and sometimes we'll go around meetings to update people and look at different approaches to make sure that everybody knows what's going on.
Okay, everyone online seems to be very quiet. We've plenty of time for any queries or comments or questions, so please do use the chat box, and we will have time at the end also to come back to those. So without further ado, we might move on then to Jocelyn Cornwell.
Thank you. Hello, everybody. It's very nice to be with you and with the panel here in Dublin Castle. I think there's a very strong connection between what we've just been talking about in some ways. So things like the discipline of meeting for just 1 hour, you know, start and finish on time, and evaluating every meeting. And not exact, I mean, in a Schwartz round, it's not exactly that people swap roles, but they do have this fantastic leveling sort of thing going on in a round, because everybody who comes to it is an equal, and it doesn't matter whether you're a porter or the chief executive or consultant or nurse or whatever. You sit as equals and listen to each other as equals. But so what I was going to talk about this afternoon very briefly was the connection between patient experience and staff experience. So Point of Care Foundation, our starting point was, how can you improve patient experience with care? That's always been our driving goal, if you like. And we became interested in staff experience because of the weight of evidence that shows that staff and patient experience are connected. And we've known about this for more than 10 years. The original research in the UK, in England, was based on analyses of the annual staff and inpatient surveys, which showed very clearly that there was an association between the results of both, and that organisations that did well on patient experience also did well on staff experience. So that told us that there was an association, but it wasn't until 2012, actually, with work led by Professor Jill Mabon, that she managed to show that it's actually the staff experience that comes first, that it's the antecedent, that if staff have a good experience, it shapes patient experience for the better. The only exception to this is ambulance trusts. So ambulance trusts, certainly in the UK, are the outliers and quite different from other trusts, because in ambulance trusts, what we see is very high patient satisfaction and generally very organizations that are very challenged in relation to staff and staff experience. Staff highly stressed and not very happy. So that's odd and really deserving of, I think, research. But so that gave us a lot of information that, based on which we started the Schwartz round. But so I think it's interesting to look at the next slide, which tells us about what matters to patients. And this is again based on analyses of patient surveys in the UK and in the United States. And analyses of literally millions of patient responses, and the themes coming out of them tell us that the top three themes for patients are three things. One is the quality of the teamwork around me. So how do I feel about how the clinicians and the support staff who are all involved in my care, what do I think about the way that they get on with each other, the way they communicate with each other? Do they listen to each other? Essentially, can I trust this group of people to work well together on my behalf? So the second big thing is always trust in the clinicians looking after me. And the third is, how do I feel treated as a person? Do I feel like I'm just a clinical case? Do I feel like I'm an object of clinical interest? Or do I feel that treated like I'm seen as a person, spoken to as a person, and that how I feel as a person matters to the staff? So those three things, I think, are really significant. And I suspect that most staff aren't aware of them. They might think that their own interaction with the patient matters a great deal, but they probably don't put enough value on the quality of the relationships around that work in terms of building trust with patients. Now, again, the link here that I want to make is back to the Schwartz rounds, which are a forum that takes place once a month, where staff can come together as equals and talk to one another about the emotional and psychological impact of the work. And the importance here is this is just one slide from the national evaluation of the implementation of the Schwartz rounds in the UK. And what it shows is that for staff who attend the rounds regularly, there is a statistically significant improvement in their psychological well-being. So what you see here, the two graphs, is that you've got the befores and afters here. So on average, when you survey any group of healthcare workers, and this would be the same, I suspect, in Ireland as it is in the UK or indeed in North America, is that there is a relatively high level of stress going on amongst healthcare professionals and support staff. Typically, around a third of the staff would have what's called psychological caseness. That's to say that if they were to go to their GP and report how they were feeling about sleep, fatigue, emotional well-being, and so on, that the GP would refer them on to something else. So that's psychological caseness. Now, what you see here is a comparison in the same trust of people who did and did not attend the rounds, okay? Now, for those who didn't attend, they started at the beginning of the year with psychological caseness of 37% in the population, and that didn't change for those who attended over a period of 8 months. It was still pretty high, around 34%. Those who attended rounds, which is interesting, seem to be self-selected for being more psychological well, if you like. So they started at a better place, 25% of them with psychological caseness. But for those who attended regularly over a period of 8 months, that halved. And the significance here is that we know that stress detracts from teamwork, that stress and depression and burnout particularly detract from the way in which people treat each other as human beings. So the participation in the rounds is contributing to those elements that make patients feel better. Okay, and the last slide is just to show, this is from feedback from Schwartz round on the basis of the feedback sheets, is that what you can see is that one of the questions is that we ask people to rate is, today's round will help me work better with my colleagues. And a very, very significant proportion of staff are saying that one outcome of attending rounds is that they feel that they understand their colleagues better and that they communicate with their colleagues better, and therefore that they work with their colleagues better. And again, that links back to the patient's experience, because if the team around you are communicating well, we know that that makes patients feel better.
Great, thanks so much, Jocelyn. One thing that interests me there from your slides were the number, the 37% of at the start that did not attend, and the people who attended actually had a lower 29%. Is that a common thing, that maybe people who don't necessarily need to attend as much as others attend?
Well, this is the only research that we have, but it's certainly one of the things that people say a lot in organizations. They say, of course, you know, I wish my colleagues who would benefit more than I do would attend alongside me. And that's an issue, because of course you, for something like a Schwartz round, you would never want people to be required to attend. It's always got to be on a voluntary basis. I still think that it's important in terms of impact on the wider culture of the organization, and that it will reach those who don't attend. That the experience of very different types of conversation that take place in a round, again, the research shows that some of that spills over to outside of the round. So it may be that people who would not voluntarily go and attend a round are beginning to experience having different types of conversation outside of that forum.
And as I was looking at that data, Jocelyn, the other thing you could say about it is that 25% of the people did have psychological caseness. Yes, so while as a total sample, less have psychological caseness, still 25% are exactly the same as the 37% in the other group, just somewhat less of them in the group. Exactly. That's all it really says. It doesn't say that overall, if I'm okay, I'll go to Schwartz round. If I'm not okay, I won't. No. But the message is that the Schwartz round needs to reach out as well from the participants to the wider, and naturally will people start to work better with each other. They'll work better with people who weren't even at the Schwartz round.
Indeed. Yeah. And I think that halving of cases over a period of just 8 months is extraordinary. Amazing. Actually, and we had not anticipated that being one of the outcomes at all.
Fantastic. Any other questions or comments?
I think one of my questions, well, Mandy, do you think you'd see a similar effect from people who are attending the big room and the work that you're doing? You know, I think there's a lot of, you know, in this work, I think, you know, these are very conscious spaces, whether it's the Schwartz round or the big room, where people are at their best selves, and we can really focus on, you know, the best of our behaviors, how we make things better. And I think ultimately that becomes culture. I think this is really the best way to change culture is through good work, I think. And two really nice examples of that.
Fantastic. So we're just going to finish off now with Stacey, who's going to talk to us about our exciting connections and opportunities with the Q community. Thanks, Stacey.
Great, thank you, and great to be here and great to be talking about Q in Ireland. One of my reflections of the conversation so far is this golden thread that's running through our examples around culture, as you say, and also a values-based approach to both looking after people, improvement, and supporting staff. And when I think about the importance of learning and networks, and I will talk a little bit more about Q and what it is in a second, actually learning as an individual is a process in itself. And then you're learning with others in the group, whether that's through the round or whether that's through the big room, and then actually you might not even realise that you're taking that learning outside of that room, and there is that ripple effect. And I think that's the commonality. And I would also bring that into conversations about peer networks and joining a variety of different networks, including Q. For those of you who don't know much about Q, I think it's bold in aim, and very simple at the same time. So we're trying to make it easier for people to learn and share and collaborate. We are in a privileged position to have some long-term investment in infrastructure, essentially trying to bring together existing skills and also recognise that there are billions and billions of pounds that are spent on innovation and improvement, and we want that to stretch as far as possible. And we're doing this through people and relationships and connections. And we're trying to break down some of the silos that exist through a network of people who have some knowledge and experience of improvement, who want to work together and learn from one another. And we're boosting that through focuses on particular topics, providing learning spaces both on and offline for people, and encouraging different ways to collaborate and to support individuals to learn how to do that. I think it's unfair to have an expectation that individuals working in health and care will join a network and suddenly know how to convene a group of people or to run their own micro network. So part of our responsibility is building some of that capability as well. We're also providing a variety of different funding spaces for people. So we have about over 40 special interest groups on a variety of different topics, from pay production to join work, for example. And some of the barriers that are in place for those individuals getting together is actually meeting room space. And my organisation aren't able to pay for my travel and accommodation, for example. So through Q, we can provide more kind of pockets of funding for people to enable them to get together and to do their work. Improvement happens in pockets. If I was to draw a map of the UK and Ireland, I would be able to draw some red dots where we're having those bright sparks of improvement. What we're trying to do is build more connections in order to share and scale what's happening. I think in improvement we can be really ambitious about the timescale for different projects and programs, and it's often teams who have very little time. They're isolated in organisations often because the improvement team sits in this part of the organisation and they're the people that look after improvement. Not the world over, obviously. There are some organisations that really do take a whole kind of system approach to improvement. It's really, really tempting, therefore, to rely on ideas and views that are readily available that you can kind of grab hold of. And that means that sometimes what we're not doing is opening up what the other possibilities might be. Therefore, we're losing some learning in that process if we're not able to learn from others about what has happened before and what they've learned from both something being a success or not. Some of the benefits, I think, of being in a network is a network like Q is to develop some of the skills that you already have, to participate in different ways and collaborate and meet people that you would never have met. At the event this morning, a Q member, Laura, was talking about randomised coffee trials, whereby you're meeting usually a stranger once a month, either through Skype or on the telephone. You're having a conversation about what it's like to work in your world. And we have examples where some great supportive relationships have developed out of that. So some of the things that we're doing are trying to be really practical in order to make change happen in a really manageable way. So whether that's using a particular methodology through your meeting where everybody has a voice, there's some real links to the flow coaching work here, liberating structures, for example. So there are lots of different things that people can draw on. We're really delighted to be here today in Ireland talking about Q. There's lots of information on our website, and very happy to chat more to others. Thanks, Rachel.
Fantastic, thanks so much. And there'll be lots of more information coming out in the coming months regarding joining the Q community, and we're very excited about that. So we might finish up actually because the conference is about to kick off again. Did you want to say anything before we finish?
Well, just to thank all our speakers. It's been a wonderful morning. I'm glad we've been able to share some of it with people who weren't able to make it. And we want to build this community right across Ireland.
Yeah. Fantastic, thanks so much. And just from our perspective, QItalktime is one of the ways we try to connect people across the country with respect to quality improvement. So it is every Tuesday, every second Tuesday between 1 and 2 p.m. This is recorded. You will be able to access it on the website afterwards. Our next talk time is a follow-on talk time on the National Quality Improvement QI Toolkit. So we will be giving you some practical tips on its use. So hopefully you'll be able to join us there for that. So thank you very much for joining, and if there's any follow-up that you need after this, please email roisin.breen@hsc.ie or Naomi. You'll see both those emails there at the bottom. And thank you very much, and hopefully we'll see you in Tuesday, 2 weeks' time. Thank you.